everyone. Thanks to Dr. Christmas for the introduction. Thanks for the EPIC conference to invite me for that talk. I hope you can all see my screen and the camera. So today I'm going to talk in a practical, hands-on manner about how to critically appraise any paper, basically in medicine. And I'm going to focus on randomized controlled trial with a hands-on example from the New England Journal of Medicine as a paper. First of all, I have no conflict of interest or no disclosure besides being part of the EPIC committee. Basically, we're going to talk about just critical appraisal of RCTs or randomized controlled trials. You know that we have different trials, different study types in medicine, and I'm not going to talk about all of them. I'm going to talk about the most important one of them, which is RCTs. So when you see any new paper about a randomized controlled trial, you have to think about its internal validity first. Is it designed well? Is its methods good? Is the patient selection, the statistical analysis, everything is going well or not? Just to minimize the bias, okay? And then if it's internally valid, you can go forward and read the results. And then you have to critique the results. We'll talk about it in a second. And then once you believe the results, and now the study is internally valid, the results are you agree with from your interpretation, then you can think of it, is this study now can be generalized, can be applied on my patient population that I see every day in my clinical practice? So that's the thing you should think about when you see any paper. So the paper I'm going to use now is the use of acetazolamide in acute decompensated heart failure with volume overload, and this was published 2 years ago in the New England Journal of Medicine. My focus is not on the paper itself. My focus is on how to critically appraise any RCT paper. So the first question you should, regarding the internal validity or the study design or the methods, you should think, is the research question the authors propose is valid or not? Is it focused? And to know if it's focused or not, we follow the PICO approach. And PICO means P means population, I means intervention, C means comparison to another intervention, and O is outcome. So because when I do a study, I have to select a population that reflects my daily practice. If it's different, then there's no point. It has to really match most people's clinical practice. We'll see that. So you have to decide, is this population adequate really for that study? And you have to see an intervention clearly outlined, comparison with another intervention, and then the outcome is clearly defined before even doing the study as a primary endpoint. You can have secondary outcomes as well, but we're talking about the primary one now. So I just got screenshots from the paper itself. And as you see, I'm looking now to see in the methods section, what are the PICO, all right? The patients. So as you see here, they said, they clearly define the PICO, the patients. Adult patients who are admitted to the hospital because of acute decompensated heart failure, and they have to mention how do you say it's heart failure? They said it's clinical sign of volume overload like edema, pleural effusion, or ascites, and BNP higher than a certain number. So they have to be really clear about inclusion criteria. Which patients are we talking about, okay? And then it also mentions the exclusion criteria at the bottom. So you have to have inclusion and exclusion criteria. That's clearly defined. That's the first P of PICO. And then you talk about the intervention. Do we have clear intervention? Do we have clear comparison? And as you see here, they randomly assign patients 1-to-1 ratio, means like 50-50, to receive acetazolamide IV or placebo. So you have clear intervention and clear comparison as well. And so we know now the P and I and C, and we don't know the O yet. So the O will be in the endpoints or the outcomes is successful decongestion. And to be clear, they have to really define how they measure that. So they said absence of this initial signs they measured for volume overload, edema, pleural effusion, and ascites, assessed by a cardiologist. So that's really good criteria, I would say. So if you go to that initial thing for internal validity of the study, is this did they define the P and I and C and O for the research question? Yes, they did. Is it really good criteria? Yes, I think so. So that's the first point we think of, okay? And then the next step is the patients randomized. Are they randomized to both arms of the study or groups, or they just pick, or the doctor picks for them? So the best approach is to randomize, of course. And when you randomize, you have to make sure the randomization is appropriate, like computer system, not a coin flip, for example, okay? And then once the patient is randomized to drug A and drug B, of course, he doesn't know it's like placebo or acetazolamide. The doctor shouldn't know as well, neither the patient or the doctor. That's what we call double-blinded. And then you see, was the allocation concealed? Means how was the allocation to the study arms secret, kept secret, basically. And then we have to test. So the authors claimed, for example, like they did good randomization, good concealing, nobody knows which group the patient is, and blinding, of course. And we have to judge, is this randomization successful or not? The study also has to have a protocol. And the blinding is one of the most important things as well. So if we look at this method section in the paper, you will see they said we did multi-center randomized. So it's randomized. Parallel groups, like two groups. Double blind, it's really good. So there's 3 different levels of blinding. Single blinding, the patient only doesn't know. The double blinded doctor and the patient doesn't know the treatment. And also there's triple blinded when the statistician doesn't know, just comparing drug A and B, and then the PI only knows which is A, which is B. So double blind is the gold standard. So they did the gold standard of double blind, placebo controlled. Usually you can argue about placebo controlled part. Usually you should choose the standard of therapy. So the standard therapy in acute heart failure is furosemide. So it would have been better if they choose furosemide compared to acetazolamide. That would be better. But again, placebo is all right in this case, okay? And they said, very important statement here, they didn't use any industry involvement. There's no pharmaceutical companies that involved, no funding from pharmaceutical companies or any other institution that can give conflict of interest. So regarding the randomization part is there, double blind is good as well. And they also mentioned here, as you see, they published the protocol, which gives a lot of transparency that we can go back and see the protocol since it's published and compare, did they really follow the protocol or there was any deviation of the protocol? If they did the protocol was published and they really followed it step by step with no deviation, that's a really good sign, okay? So that's regarding another step of deciding if the study has internal validity. And then you have to see if the sample size is adequate, did they have a good number of sample size? Was it just one center or multiple centers, one hospital or multiple hospitals? Is in one country or different countries? Of course, if you have more sample size, multiple centers in multiple countries, this would leave that the internal validity of the study is really good and we can really trust the results. What happened here is they choose 2,915 patients, which is a good number. And they had them randomized equally, 1-to-1, 50-50 into 2 groups in 27 sites in Belgium. So it's one country, but multiple hospitals. So of course, I would like to see like 10,000 in 20 countries and like 100 sites. That would be the perfect. But this study design is good as well. We'll never have a perfect study. So this is good, all right? And then you have to decide, if they say the study was randomized, we have to really judge that. Is the randomization successful or not? How are we going to do this? You look at table 1. Table 1 is the baseline characteristics of the study. And as you see here, those are the characteristics for each of the patients. And then it says you have 260 patients with placebo and 259 of acetazolamide. So the numbers are equal almost. And if you look at the age, for example, you see that the mean age is similar. If you look at the male percentage, maybe the acetazolamide has more males, If you look at white race, they're almost the same. If you look at blood pressure, weight, so you have to look at each of those characteristics and see if the numbers are almost equal in both groups. And this means that actually they're really represented or randomized the patients in a good way. Because if you did good randomization, those two groups should be equal in their baseline characteristics. That's how statistics is. But if you see like one or more characteristic is more represented in one of the groups, that's not good randomization. So you have to be aware of this. The next step is to decide, did both groups get the same level of care? Meaning, and you can guarantee this by blinding. So if the doctors are blinded, the patients are blinded, the doctors treat both groups equally. They don't say, oh, this is the placebo group, we don't really take care of them, we just focus on the acetazolamide group, because they don't know. You would assume they treated both groups equally, which what we want, right? The other thing is, how many patients were lost to follow-up or dropped? Let's say you started with a study like this, and then you lost, let's say 50% of patients. That's really bad number. I can't really trust this study because not everybody continued the study till the end for some reason. But let's say only 5 to 10% drop. That's good. Even like 20%, some studies can do that. So that the less numbers of patients who drop or are lost to follow-up, the better. Okay. So let's see here. As you see, placebo was stick to 160 and acetazolamide was 259. That at the beginning of the study, that's the baseline characteristics. If you look at the end, placebo is still to 259, so the same number. Acetazolamide was 256, maybe it's like, sorry, placebo is one less, one dropped from placebo, and acetazolamide, 4 dropped or 3 dropped. So again, 4 patients dropped from almost like 500. That's a very, very low number. So I would trust this study more. It's more internally valid. There is no loss of patients, and there's which gives us trust in the results more. And then once those all the questions that we ask for the internal validity, to know if there's bias in the study, if it's well designed, if the methods are adequate for the purpose, after we look at the research question. So first you look at the research question, then you look at the internal validity. In this study, I think it's internally valid. Maybe if we have more countries, more number of patients, that would be better, but it's internally valid. Then the next step is to look at the results of the study or the statistical analysis. And then you have two methods of analysis actually in any study. Either to treat, let's say we have 5 patients or 10 patients who dropped from the study. Do we include them in the analysis as patients who had like 0 of everything? That would be the best method. We call this intention to treat analysis. We analyze all the patients, whether they were dropped from the study or not, whether they continued the study or not, whether they, let's say, took the placebo and then they switched later to the actual medication. We just analyze everybody as we want, okay? That's the best method. So whenever they say they did intention to treat analysis, you trust this more. If they said per protocol, meaning they excluded the patients who were dropped from the study from the analysis itself, that's not a good approach, okay? And they have to mention. If they didn't mention any, meaning you have to know what they did and they have to document it. So in this study, for example, if you see, they mentioned here intention to treat, meaning they included everybody, whether they dropped or continued the study or not, or they changed arms or whatever happened, they include them, which is reflective of real world practice, and it's really good to depend on that kind of studies. Per protocol is not the preferred approach of analysis, okay? So once you confirm that question, the PICO question, and you say the study is internally valid, you look at the statistical analysis. Oh yeah, they did intention to treat, which is good. You look now at the results itself. Let's check the results, because if the study is not internally valid, has a lot of biases, why would I look at the results, right? It's useless. It will be whatever it is. I'm not going to rely on it. Okay. By now, I can go confidently into the results section. They have to mention if they did power calculation for calculating the adequate sample size for the question, but they have good numbers, so I'll assume so, and it should be mentioned in the protocol. And the other thing is they do really statistical analysis in a good way. I'm not going to go into this in detail because this needs more statistical background. Don't have time for this today, but that's one of the most important things as well. You have to look, they report p-values only or confidence interval as well. Usually we want both p-values and confidence interval. And when the confidence interval is narrow, that means it's precise and good. If it's really wide, it's not precise, not good. Okay. And then you look at the treatment effect. Is it large enough to be clinically different? Let's say the acetazolamide compared to furosemide made congestion better by 1%. Is that really clinically significant? No. 1% is nothing, right? But let's say it improved it by 30%. Oh, it's a good number then. So as a clinician, you have to judge, is this treatment effect, even if statistically significant, is clinically significant? Does it really make a difference in the treatment? And that's how we mean by how large is the treatment effect, right? And then if the treatment is good, you see, oh, this is really good treatment. They have to put another table about the risks and the side effects of the drug. And then you can compare, maybe this drug is really good, we're testing, but then the side effects are really bad. So it's a benefit risk ratio, right? For anything in medicine. So let's look at this table, for example. So now you're comparing placebo to acetazolamide. Let's focus on the primary endpoint they mentioned, which is successful decongestion. So here are all the endpoints. I'm going to focus on the first one only, which is primary endpoint. And then you have placebo and acetazolamide. So it said that the successful decongestion within 3 days after administration of the drug in the placebo group was 79%. And then in acetazolamide was 108. Sorry, it's not percent, it's number. 30% and 42%. So acetazolamide made it better compared to placebo by 12%. You can say, oh, this is really good in terms of numbers clinically or not. It depends on your clinical judgment. So then the difference is only 12%. So this is regarding the first outcome. I'm not going to go into the other outcomes, but I can also compare them and see. But again, it's not just a matter of 12% of improvement of decongestion. You have to look at the adverse events as well. So those are adverse events. So for the renal safety endpoint, meaning like acute kidney injury or anything related to the kidney, it's more in the acetazolamide. It's 2.7 compared to 0.8%. Especially the GFR decrease, as they say here. Metabolic acidosis were none in both groups. Hypokalemia was more in acetazolamide. Hypotension was more in acetazolamide. So you have to judge, is this 12% really worth that side effects or not? It's a clinical judgment, right? And you have to be like an expert or a consultant in the field to decide, oh, this is really good or not. And when guidelines are written, they have to take that into account, benefits versus risk, okay? So we don't change our management just based on one paper, but this is a start, okay? So once you look at the results, you're happy with the results. So I looked at the research question. It's really good. This is well designed. We look at the internal validity, the study design, the methods, everything looks fine. Then we can go next to the results, which we see, yeah, the drug is better than placebo, but maybe it's not compared to really furosemide, but 12% of improvement versus some side effects. You have to measure it's really good or not. And then once you say, okay, I think this drug is good, what's the next step? Then you have to think, is this generalizable or applicable to your own local patient population? As you've seen in this study, it was really done on white patients more. And maybe I live in a certain area of the world that has different race. Will that really apply? I don't know. It was done in Belgium. Maybe Belgium patients have different lifestyle. Does that apply in the UK or the US? So generalizability is different. Maybe the study is really good, but can only be applied to the exact patient population was included in the study. That's why if you have multiple countries, multiple sites, different genetic composition, different races, different everything, diabetics, non-diabetics, chronic kidney disease, whatever, you can say, oh, this is really generalizable. So again, just to remind you, you think of 4 questions. is the research question well designed in a PICO format? Then you look at the internal validity. Is the design of the study really good? There's no biases. Then you read the results itself. Is the medication doing well? And then you look at the side effects. Is there side effects or adverse events? And then you look at the generalizability or the applicability in your own patient population. Maybe this guideline will be adopted in Belgium, but nowhere else. It depends, right? But let's say if this is repeated in multiple countries, multiple sites, more patients, maybe it would be more generalizable. Okay, so this is a question that can be answered differently based on where you work, where you see your patient, how are your patients similar to the patient population in the study. Okay, and to know more about the patient population and answer that question of generalizability, doing a subgroup analysis is important. So let's say here, this is a subgroup analysis of those patients comparing both placebo and acetazolamide. So you have a line in the middle. If the results is on the right of the line, means acetazolamide is better. If it's on the left, means placebo is better. So this is placebo, and this is acetazolamide. And if you look at the confidence interval for overall patients, you would see that that line represents the confidence interval. It's not narrow, it's a little bit wide, which means the results are not precise. However, it does not cross the line or touch the line in the middle, which means acetazolamide is better compared to placebo. But again, the confidence interval is a little bit wide. If you look, for example, at the heart failure for people who have less than 40% ejection fraction, you will see that the line is really wider and crosses the midline, meaning there is no difference between placebo and acetazolamide in patients less than 40% ejection fraction. So this limits the generalizability. I cannot really use acetazolamide then in patients who have less than 40% ejection fraction, but I can use it maybe in more than 40. So this subgroup analysis is really important. The authors have to provide that so that you can choose which patients can benefit from the drug, right? For female sex, for example, it looks like female, they didn't really, there's no difference between placebo and acetazolamide in female sex, but there was some difference in male, which maybe doesn't make sense clinically. So maybe if we repeat this study on multiple patients and multiple centers, multiple countries, we could interpret it better. So basically, what I'm trying to say is, does this study has good research question? Yes, it does. Does it have good internal validity? Yes. Does it have good results and promising results? Yes. Maybe the side effects a little bit more. However, is this generalizable? I don't think so. Because we need more patients, more countries, more subgroup analysis on a wider scale, including race and other stuff, and then we can decide maybe. But this is a good start for bringing a medication that we have in medicine for many years and we don't use it. And now maybe it can be promising cheap in heart failure if we really benefit from it, right? So that's my talk. I used the CASP and the Oxford checklist for critical appraisal, and the article is from New England Journal of Medicine. So I hope this is useful for you. You can follow any those checklists for any randomized control trial. Thank you.